So I'm going to talk to you tomorrow, this morning about prenatal and postnatal CMV infection. So I'll just start by kind of going over the kind of presentations of prenatal and postnatal CMV, how it's diagnosed, the kind of difference in diagnosing the two, management and outcomes as well. So starting with prenatal CMV or congenital CMV, it's the commonest congenital infection in the UK, and the prevalence kind of worldwide is between 0.1 and 2% of births. In the UK, I kind of found varying figures. In our local guideline, it said 3 per 100, which seemed really quite high, but in others, it's kind of been more like 7 per 1,000. So kind of transmission occurs via the placenta. Most often this actually occurs later on in pregnancy, but the ones that cause a significant disease are probably those infections that occur during the first half of pregnancy. And usually it's a primary infection in the mother, but it can also be a reactivation of the virus as well, and about 1% of cases. Importantly as well, the people who are in higher socioeconomic groups are more likely to be CMV negative. There's an association with kind of poor living conditions, poor sanitation. So actually in a lot of countries, they have people have a lot higher rates of CMV by the time they're pregnant, whereas in the UK, it's only about 50% of people are thought to be CMV positive when they're pregnant. And importantly as well, only 10% of those that are affected are actually symptomatic at birth. So why is it so important? The reason why is that it has a significant association with morbidity and mortality, and mortality can be up to 30% in babies with significant infection at birth, serious infection at birth. And those that survive, the outcomes are quite varied, but they can be quite poor, and up to kind of between 40 and 90% will have some kind of impairment. The most common impairment is hearing loss, but it also has an association with cerebral palsy, cognitive impairment, and even autism as well. For those that are asymptomatic, the prognosis is better. There's much less kind of association with cognitive impairment, but importantly, there is still an association, and some children that present to clinic with cerebral palsy are later found to have maybe evidence of congenital CMV, and 15% of those that are asymptomatic will have some level of hearing loss. So as you probably all know, there is no vaccination for CMV, there's no treatment during pregnancy, so the most important thing is actually preventing it. So this is a slide that I took from the CMV Action website, which is a really useful resource for parents. It gives a lot of information about having a baby with congenital CMV, but also they do a lot of work on trying to prevent it, and this is probably stuff that's all very familiar to us now, kind of keeping with the times, but it's just the importance of hand hygiene. CMV is spread by secretions for bodily fluid contamination. So it's just really important to wash your hands. It's particularly important for those who, for pregnant mums who've got toddlers and young children, because obviously if they're at kind of play groups and mother-toddler groups, then these children are always putting things in their mouths, etc., etc. So it's just kind of reiterates the importance of this. So when should we suspect it? So the kind of classical features are like a petechial rash, purpura rash, and probably everyone remembers the kind of blueberry muffin rash. It's quite a common exam question. These babies can have hepatosplenomegaly. They're often small and particularly have a symmetrical IUGR, and in keeping with that are often microcephalic. The babies can be jaundiced as well, and they can develop to prolonged jaundice, and in particular conjugated jaundice. So something to think about in those babies that present to PJ clinic as well. Obviously it's a spectrum of disease, so they may have some of these features or just one of these features, or be very, very unwell at birth. So this is a picture of the kind of blueberry muffin rash. That's another one there. This baby's obviously a bit jaundiced as well. These two are, quite extreme versions of it, but it can, it can be much more mild and can just be some petechial spots, etc. So other things to look for are on your laboratory and blood tests. As I mentioned, conjugated jaundice, thrombocytopenia without an obvious cause, and also low white cell count anemia as well. Sometimes these babies will present with neurological findings. In particular, it's important to look for it in babies who have seizures with any unknown cause. Things that are noted often on imaging are intracranial calcifications, ventriculomegaly, periventricular cysts. There's also a whole host of other things that have been associated with it. This sentence here I kind of took from our local guidelines. So it's a huge thing, a huge range of things that can be noted on imaging. And also on ophthalmology examination, babies with kind of cataracts or chorioretinitis should you need to think about CMV, and those that have a failed hearing test as well. So postnatal CMV, these babies present after birth, so they aren't born with the kind of classical features. They're often not IUGR, or unless they IUGR, obviously for another reason, and actually develop a kind of a syndrome, 2 to 3 weeks or usually later into life. So transmission occurs like with adults and children, it occurs via bodily fluids. So in babies, that's via blood products. Obviously, we've eliminated that now essentially because of using CMV negative blood, but it can occur around the time of delivery with sarcophageal secretions, but probably the most common cause nowadays is actually via breast milk. So in term babies, they tend to not be affected by the postnatal CMV. This is thought to be probably due to transmission of IgG later on during pregnancy, but also they just tend to be more mature and obviously more resilient and can kind of deal with the infection. Whereas in preterm and very low birth weight babies, so our kind of population group that we see, they can cause a really significant infection. So it's something to often think about. And they present with a sepsis-like syndrome where they become very unwell, and it can cause a pneumonitis, even an enteritis and a transaminitis. Again, these babies tend to have low platelets. So how is it diagnosed? So the kind of gold standard for it is PCR, and in particular urine PCR. The reason why urine and saliva tend to have a much higher yield of the virus compared with blood. They're kind of the gold standard for treatment. Saliva is obviously a little bit more difficult because if the baby's breastfeeding, then the virus could potentially have been in the mother's breast milk rather than in the baby itself. So they say if you take a saliva sample, it's best to take it at least 1 hour post breastfeed. And importantly, if you take a blood sample, it's actually a negative sample does not exclude CMV. Whereas a urine sample, particularly a urine sample within the first 3 weeks of life that is CMV positive, is pretty definitive for congenital CMV infection. Serum IgM, you can also take a serum IgM, although it's not as specific or sensitive. There's not a huge amount of point doing IgG in a newborn baby. And then obviously having a look at the maternal serology and PCR results. If there's evidence of recent infection in the maternal serology, then that would be a clear indication of congenital CMV. For postnatal CMV, you have to kind of get a result after 3 weeks of life. And even after 3 weeks of life, a positive PCR, urine or saliva PCR, is not actually definitive of a postnatal CMV, because babies will shed, and adults, everyone sheds the virus for quite a long time, for weeks after they initially infected. So even if you're doing it 4 or 5 weeks, this could still be a congenital CMV. So in order to try and determine whether it is a postnatal CMV, you can look back at the dry blood spot at the Guthrie and do retrospective PCR testing on that. It's not as reliable, but the kind of combination of the two in the setting of a clinical picture of a deterioration with no obvious kind of sepsis cause or something like that, with this kind of hepatitis and thrombocytopenia and kind of sepsis-like syndrome. So that kind of clinical picture with a negative PCR at birth on the dried blood spot and a positive PCR later on would indicate postnatal CMV. So other investigations that should be done, obviously doing full blood works because of the effect it can have on platelets and LFTs, etc. It's important always other congenital infections can present in similar ways, so you should carry out kind of torch screens on these babies if the mum hadn't had one in pregnancy, and important to do kind of ophthalmology reviews, neuroimaging, audiology assessments, etc., even if they've passed their newborn hearing assessments. So how is it managed? Now, there is evidence for congenital CMV on the use of ganciclovir or valganciclovir. The main kind of concern with using this is that it can cause neutropenia and thrombocytopenia. And importantly as well, the evidence for using this is that it should be started within the first 4 weeks, although there's not a lot of evidence kind of either way of starting it later, so we don't know whether it has much of an effect, but it just highlights the importance of obviously trying to identify these babies as early as we can. So IV GANs, there was a trial kind of using IV ganciclovir for 6 weeks, which noticed a reduction in hearing loss in those babies that had presented at birth or shortly after birth with significant CNS involvement. IV ganciclovir was then compared in another study with oral valganciclovir, and it found that actually oral valganciclovir was associated with better neurodevelopmental outcomes and hearing outcomes at both 12 and at 24 months in follow-up assessments. However, there is kind of a theoretical risk of both infertility and malignancy. There's no kind of studies in humans to show that this is possible, but in animal models they have shown infertility and malignancy as a risk of treatment. So obviously that you know, in counselling these mums, we do need to kind of counselling these mums and dads, of course, we need to explain that that's a possibility, theoretical possibility. So in terms of kind of the treatment choice, so in our kind of local guideline, it just kind of talks about those two, but in the European guidelines, they've kind of separated congenital CMV into 3 different kind of categories. So severe disease, where the babies are very unwell at birth, or when there's CNS involvement or a definite hearing impairment already at the start of treatment. And if there is CNS or hearing kind of impairment, they say you should have the 6 months duration. But kind of if it's life-threatening, it's more depends on the kind of clinical opinion. For moderate disease, so this is when there's kind of babies have symptoms for at least 2 weeks, and there's at least a couple of features or kind of abnormalities on the bloods, and then you should consider treatment. But it wasn't kind of didn't say either way, we should definitely give it or not. But those who have very mild disease, just 1 feature, or you know, otherwise very, very well, then probably no treatment is required. And follow up, the babies should obviously, whilst they're having treatment, they need to have their bloods regularly monitored, and then kind of all the follow-up should be arranged in terms of neurodevelopment, but also in terms of kind of having regular ophthalmology reviews and audiology reviews, etc. So for treatment for postnatal CMV, there's not a huge amount of evidence for giving the antivirals like there is for congenital CMV. There's kind of some mention of using ganciclovir in very, very severe cases. The one thing that is really important is whilst it's likely that it's transmitted via breast milk, we shouldn't withhold breast milk even with seropositive mothers, because obviously the babies that are affected by postnatal CMV are our kind of very low birth weight and preterm babies, and the kind of benefits, as we all know, we've all done neonates for long enough now, that you know the benefits of giving breast milk far outweigh the risk probably associated with postnatal CMV. And the general kind of consensus is that postnatal CMV doesn't have a huge is probably not likely to have a huge impact on kind of neurodevelopmental and hearing outcomes like CMV, congenital CMV does. The majority of evidence points that it doesn't have any effect. There is some evidence, there's a couple of papers that when you first thing you do when you put into kind of Google postnatal CMV, a couple of papers do come up that show that there is a possible effect. One of them, which was quite interesting, was this paper. It was a very large study actually, with 300 in both groups. This was all in preterm babies or very low birth weight babies, and actually it showed that there was a quite significant difference in the incidence of bronchopulmonary dysplasia between the two groups. So those that had postnatal CMV had a much higher rate of BPD, 71% compared with 53%, which was thought to be, which was kind of statistically significant. Although they did kind of mention in the paper that they were unable to account for many other variables which would contribute to babies developing BPD. So I'm not quite sure how reliable this is. Obviously those ones that have screened for postnatal CMV were probably those babies that were sicker and requiring longer periods of mechanical ventilation and had you know, other reasons to be sick as well, which would all contribute to the development of BPD. And there's been other studies. This one kind of shows that there wasn't, they looked at a number of different outcomes, kind of PVL, BPD, ROP, IVH, and they show that there wasn't really any difference between the two groups. And again, this was from the same study. This was looking at their kind of follow-up. You know, head circumferences were essentially the same in both groups. Bailey scores were there was no difference between the two groups, and importantly, hearing impairment there was very low rates of hearing impairment in both the infection group and in the control group as well. So in summary, congenital CMV infection is a very important cause of morbidity and mortality in neonates, and it's really important to recognise these signs early and start the treatment early when indicated. Counselling of these parents is probably really important, because there are significant risks associated with the treatment, and also it's quite difficult to determine, you know, to what extent the baby is going to be affected in terms of their long-term outcomes. For postnatal CMV, this is probably an important cause of morbidity in neonates that we probably don't consider quite as often as it's actually relevant, but it is an important cause. But majority of the evidence shows that it's got no association with worse outcomes, but it's something important always to consider.